Hello and welcome to the Medic's Guide. Today we're going to cover Addison's disease. So grab your pen and paper and let's get started. So to help you understand what Addison's is, we first need to look at something called the HPA Axis. And the hypothalamus in the brain contains neuroendocrine cells which secrete something called corticotropin releasing hormone, or CRH. And this then acts on the anterior part of the pituitary gland, causing the secretion of ACTH, or adrenocorticotropic hormone. This then acts on the adrenal cortex to produce cortisol and sometimes a small amount of aldosterone, although that's mainly made in other ways. Now, these are two essential hormones made in the adrenal gland and they have many functions. It's also important to add that there is a negative feedback loop in which cortisol can suppress the release of ACTH and CRH. Now, systemically, cortisol has many effects, including on glucose metabolism, usually causing an increase in blood glucose levels, and aldosterone is essential for sodium and blood pressure regulation, and it usually causes an increase in sodium and a reduction in potassium. Now, Addison's is an autoimmune condition in which destruction of the adrenal glands results in reduced cortisol and reduced aldosterone being produced, and it's the number one cause of primary adrenal insufficiency. It's also most common in women around the age of 20 to 40. Now, adrenal insufficiency has a number of other causes, and there's a mnemonic used by many called Addison, which covers the other causes. So we've got autoimmune, degenerative, drugs, infections, secondary, there are other causes, and neoplasia. Just remember that and you've got all the causes of adrenal insufficiency nailed. Now, Addison's has quite non-specific signs and symptoms which can often make it difficult to detect. However, there are certain things that we can find in terms of signs. So we've got low blood pressure or postural hypertension, which can easily be checked, as well as an examination of the skin to look for any signs of hyperpigmentation. There may also be a loss of hair as well. The symptoms also tend to be quite non-specific, so things like tiredness and weakness, weight loss, nausea and vomiting, changes in bowel habits, and because of the low sodium, they often have salty food cravings, and depression might be something else to look out for. Now, something very serious to be wary of is an adrenal crisis, which is a sudden drop in glucocorticoid levels. Now, this is commonly caused when a long-term patient stops taking their medication suddenly, and this will present with vomiting, abdominal pain, weakness, hypoglycemia, and hypovolemic shock, and they need urgent treatment. Now, in someone with suspected Addison's, the definitive investigation is the short synaptin test, and it involves giving patients an injection of artificial ACTH, called synaptin, in an attempt to stimulate the adrenal glands to produce cortisol. Now, we measure this cortisol level at baseline when we give the synaptin, and we normally give it intramuscularly, and then we test the cortisol level at 30 minutes and 60 minutes, and we would expect this value to double. If it doesn't double, then we know that there's a problem with the adrenal glands and we can diagnose primary adrenal insufficiency. Now, there may be some electrolyte abnormalities, so things like hyperkalemia, hyponatremia, even hypoglycemia and metabolic acidosis can all be seen sometimes. Treatment-wise, patients with Addison's are usually given both glucocorticoid and mineralocorticoid replacement therapy. So they'll often take a combo of hydrocortisone and fludrocortisone. One thing to note is that during any intercurrent illness, the dose of the glucocorticoid should also be doubled. And remember that both these medications can cause secondary hypertension. So to help you remember this all, I've come up with a mnemonic, and it's called synaptin. Super easy. Just nail this and you've got the whole condition sorted. S for short synaptin test. Younger women, non-specific symptoms, adrenal crisis, corticosteroids and glucocorticoids are the treatment. Tiredness, hyperpigmentation, electrolyte imbalances, and it's the number one cause of adrenal insufficiency. So remember that and you've got the whole condition nailed. Right, a couple questions just to finish off. A patient presents to your GP practice to receive the results of his recent blood test. He's a 62-year-old male complaining of fatigue, weight loss and nausea. and his blood results are as follows. I'm sorry I haven't got the normal values, but I can tell you that the HB is low, and the sodium is low and the potassium is high. So if we look at the answer options here, well, we know straight away that it's not going to be the bottom two because there's other abnormalities. So it could be anemia, it could be malignancy, and it could be adrenal insufficiency. Now in this question, with the blood results as well, there's nothing really to tell you about if this definitely is a malignancy, and further investigation would be needed. So we can nail it down to anemia and adrenal insufficiency. Now the way to figure this out is by looking at the sodium and potassium, and we can see that this patient is hyponatremic and hyperkalemic, and therefore this pattern would fit with adrenal insufficiency more. So that's the answer for this. A 68-year-old woman is found unconscious in the street. She is taken by paramedics to the ED, where she is found to have a glucose of 2.5. Which of the following could be a cause of her presentation? So we know that Addison's can often present in an adrenal crisis with hypoglycemia. There's also something to also be aware of when doing any blood tests. Addison's disease is the answer here. And lastly, a 28-year-old Welsh woman attends her GP with a month history of fatigue and depression. Her blood pressure is 124/80 lying and 92/58 standing. Blood tests reveal a mild hyponatremia and mild hyperkalemia. The GP arranges short synectin tests, and the results are as follows. So the expected 30-minute level should have been 580 or greater than 580, should I say. But in reality, it was only 350. So as I mentioned, it should double from this baseline level. It hasn't done that. So we've already got an idea that this could be Addison's, but some other things to point out. She's 28 years old, a woman. She's tired and has depression. Now she has this lying and standing blood pressure drop. With the hyponatremia and hyperkalemia, this is definitely Addison's disease, so we'd go for autoimmune adrenalitis. So that's all I wanted to cover today. Thank you very much for listening. Please like, comment and subscribe. Let me know if you want me to cover any other questions or any other conditions, and I'll be back with another video soon.